We're going to go ahead and get started with our Neuropathology Core Session. There will be lots of opportunities for Q&A after each speaker for this session, so please be sure to line up in the aisle mic. We do only have 5 minutes per speaker, so 1 or 2 questions each. But without further ado, I would like to welcome to the stage Dr. Thomas Wisniewski. He is the director of the NYU ADRC and the chair of the Neuropathology Core Steering Committee. Welcome.
Welcome everyone. We have a fantastic group of speakers lined up who will keep the energy level high at this dynamic ADRC meeting. The speakers span the full spectrum from leaders in the field to more junior but up-and-coming investigators. The theme is vascular pathology, and that's timely with the growing recognition of the importance of vascular pathology for the full characterization of our subjects. So what I will be talking about in, in my short intro is first the results of the Vascular Pathology Survey. I'll be giving some brief updates from 3 work groups and very briefly speaking about the new Clarity project. The Neuropathology Core leaders were extremely diligent and timely at answering the survey questions, so thank you. The vast majority of centers are using the Neuropath Form 11 for cerebrovascular documentation, and in the majority of centers, this information is linked to imaging. In terms of assessments of CAA, the vast majority are using A-beta immunohistochemistry, and about 1/3 are using Luxol fast blue staining for assessment of white matter pathology. A small subset are using CD68 immunohistochemistry for microhemorrhage quantitation, and then a number of other stains are used like H&E in a number of neuropath cores, and single cores are using Prussian blue or are working on MMP1 and MMP10 staining. In terms of assessments of atherosclerosis, all are looking at the circle of Willis, with significant minorities also taking sections from the circle of Willis or sections from other major cerebral blood vessels. In terms of assessments of arteriolosclerosis, the most common answer was looking at the overall measure for the worst of the whole brain, with some centers also giving an overall average for the whole brain, and others assessing specific regions of the brain. Similarly, for CAA assessments, the most common answer was assessing specific regions of the brain, with equal number of centers giving an overall measure for the worst of the whole brain or an overall average measure for the whole brain. In terms of cerebrovascular disease lesion definition and the cutoffs used, there was actually very good agreement across centers as summarized in this slide. In terms of linkage to imaging data, about half of the Neuropath cores linked the data that they obtained to pre-morbid imaging, and about 1/3 linked it to both pre-mortem and post-mortem imaging. In terms of the scales that are used to assess CVD, the vast majority are using semi-quantitative grading of CAA as well as semi-quantitative grading of arteriolosclerosis, with a smattering of centers using other grading systems like the VSING guidelines or Strosky or modified Calaria. In terms of publication output, about a third of centers are using this vascular data for generating publication. That third of centers are highly prolific, with over 350 publications resulting. Some of those are listed here. So the summary of the survey: Neuropath core leaders are very responsive to survey requests, and the other conclusions are listed here, and we will be circulating the results of this survey in the future. Now, turning to the work group updates, starting with the digital pathology work group, and these were slides provided by Brittany Duger. This is a very collaborative group involving many institutes, as listed here. They've also been prolific this year, publishing the results of some of their finding, giving the status of digital pathology and associated infrastructure within our ADRC network, as well as outlining the neuroanatomical sampling and staining procedures that are typically used. Importantly, recently 2 newly funded U24 grants have been awarded to develop digital pathology platforms, and both of these grants are involving multiple collaborations with many institutions. This work group is also very active in producing webinars, which are great to listen to. And if you want to share any digital pathology stories, the contact information is there. In addition, there is a modernization of Neuropathology Core and Brain Bank work group. This convened in Cold Spring Harbor Lab under these 2 chairs, and Dr. Melissa Murray provided these 2 slides that I'm showing now. The aim here is to bring together a wide range of scientists to study neurodegeneration, to bring forth a number of actionable solutions that can help build the sustainability of brain banks across ADRCs, as well as plans to disseminate their findings through a future prospective piece. In terms of actionable solutions, they are working to enhance the brain bank framework in order to meet critical unmet needs that require functioning brain bank resources and build additional capacity for external requests, as well as being able to meet day-to-day operational means. So this will also involve building out tissue sharing pipelines, addressing neurophenomics, and then also there's a need to build on training and diversity with an ultimate goal of building sustainability of brain banking to meet the ever-increasing needs for tissue sharing. Lastly, an update from the Neurobiobank work group. They've been very active and have already accomplished a great deal, as outlined in the red here, building collaborative network, coordination pipelines, and a number of protocols. In terms of the numbers of individuals consented and the evaluation of brains to date, that's listed on the left, as well as the many potential benefits of this program listed on the right-hand side of this slide. Lastly, you've heard about the new Clarity program. This also involves having a neuropathology core, which will build on the usefulness and the strength of the digital biomarkers and the brain imaging that will be linked to neuropathological data. This neuropath data will be scanned using Halo and will be uploaded into the NAC data platform, made available to researchers in the ADRC network, as well as researchers everywhere. So this will be a tremendous resource, and you'll hear more about this in the coming year or so. So next, we'll go on to some of the talks. The first speaker is Dr. Julie Schneider, who is the director of the Rush ADRC, a leader in the field, and she will be talking about Alzheimer's disease pathological workup. Are we missing significant vascular pathology?
Thank you, Thomas. And thank you for inviting me to talk about one of my favorite topics, which is vascular pathology. Here are my disclosures. Work with a big team who's made the work possible. So I don't think I have to tell people why we need to look at vascular pathology, right? We and others have shown that they really make a really big contribution to cognitive decline in aging and risk. So if you look at the Ross map cohort and you look at attributable risk, about 28% of the risk is attributable to infarcts, CAA, atherosclerosis, and arterioulnar sclerosis. And that's just using those 4 things. So we're not talking about white matter hypertension. These are other things you might see in addition to that. So a lot of what we see in Alzheimer's disease or dementia is related to their vascular pathology. However, really our neuropath workup has stemmed from Alzheimer's disease research. So our classic workup, the regions that we've taken, have been related to where plaques and tangles are. And that's been since I started with Sumera and the regions we chose. Most of us also routinely take things like basal ganglia, but there wasn't a lot of attention on what might we be missing by not looking at specific regions. Most people, as Thomas pointed out, do describe gross infarcts and microscopic infarcts in the regions sampled for Alzheimer's disease. And most of us look at the vascular diseases he showed, arterioulnar sclerosis, atherosclerosis, and CAA, though we do them a little bit differently depending on the center. So just to show the non-neuropathologists what we're looking at, I just have a picture of a gross infarct, a microinfarct, atherosclerosis at the circle of Willis, 100% of us look at there, a cerebral amyloid angiopathy, and arterioulnar sclerosis, often on a background of Alzheimer's disease. You've seen these slides before, but this was a study quite a long time ago where we looked at if you have Alzheimer's disease pathology, what is your odds of having dementia? And as your Alzheimer's disease pathology goes up, your odds of having dementia goes up. Makes sense. And you can see that in the blue line. If you have an infarct in your brain, your odds of having dementia go up to where the red line is. So we didn't know we were going to find this when we saw it, because a lot of what we were seeing in the brains of older people were these small little infarcts, something in the putamen or in the caudate, and we just give the diagnosis of Alzheimer's disease. Most of us, put the infarct lower down and didn't even really pay much attention to it. There was a pretty big increase in the odds of dementia with just a macro infarct. More surprisingly, if we add microinfarcts, this one we really did not think was going to do this. First of all, it's very sample dependent, right? So where we're looking for these microinfarcts is just relies on where we're taking these samples from. It's not a systematic sampling. So we were quite surprised when if you add microinfarcts, now your odds go up even further of having dementia from Alzheimer's disease pathology. And then finally, we looked at vessel diseases. And you can see here, I give an example with the arrows of if you have a gross infarct, microinfarct, atherosclerosis, and arterioulnar sclerosis, you've just gone from an odds of 20% that you're going to have dementia from your Alzheimer's disease to around close to 70%. That's huge. And then if you look at our cohort, in the Ross map cohort, this is people community dwelling older people. Average age is older, so they around 88, I believe, in this study. If you look here, everything that's shaded or colored means they have vascular pathology. And the colors are just denoting if they have one or more. So it's showing that you have athero and arteriolar sclerosis in red, and then arteriolar sclerosis, and then atherosclerosis in yellow, and then just infarcts. You didn't have vessel disease, but you had an infarct, which we know happens, right? You don't have to have vessel disease to have an infarct. It can be coming from the periphery. So big deal when you have vascular pathology in your brain. And our community has not ignored it, but certainly hasn't paid a lot of attention to it. Now, I could also go down the road of other degenerative pathologies, which are also important too. So not everyone needs to be studying everything, but this is certainly an important thing that all of us should be considering when we sign out pathology reports. This was from the same paper I showed at the very beginning, showing the attributable risk. And what I wanted to point out here, actually not TDP and hippocampal sclerosis, but what I was really pointing out was the things that, how they contribute, so how we added these things up. So each of these contributions was added up to be almost a third. So macroinfarcts was the highest, I believe, then cerebral amyloid angiopathy, and then athero and arteriolar had separate separate numbers, but we're just adding this up. We're just adding up these different pathologies. So the question becomes, we're adding up those specific pathologies, but are we capturing all the pathology? And so are the regions really satisfactory for where we should be looking for vascular pathology? And then I think the other thing, that I'm not going to talk a lot about this, but Thomas already alluded to it, is the granular detail. A lot of this, we're getting measurements, but we're not really using the measurements. We have regions, we're not using the regions. We have imaging technology now, digital imaging, where we could probably get some very good measures of occlusion and vessel walls. And then what other pathologies are we not getting? So for the regions, one of the things that I thought was really interesting was the watershed regions in aging. So the regions between the ACA, MCA, and PCA are regions that are vulnerable when you have vascular disease because they're watershed. There's actually cortical watershed, those are the cortical. There's also deep watershed areas in the brain. And so I'll show you some data we have on watershed areas. And we did include that in the NIA-AA criteria. It's an optional region. So if you're interested in vascular disease, I'll show you why you should probably be taking the watershed regions of the brain. How about arteriolar sclerosis? Most people give you the overall view of arteriolar sclerosis. Are there differences between regions? And I wouldn't ask that unless there was. So I'll show you some data on regional differences in arteriolar sclerosis. And then atherosclerosis, we think of large versus small vessel disease, and of course in the real world, nothing's that simple. Atherosclerosis actually can cause small vessel disease, meaning you can get artery to artery emboli, and I'll show you some pictures, and you can get small arterioles affected by atherosclerosis. So I put that in the bucket for small vessel disease, even though we think of it as a large vessel disease. And then there's a lot we're not capturing, right? Perivascular rarefaction, the perivascular spaces, white matter changes with the luxal fast blue, fine, but is that, how good is that really, right? Compared to imaging, if you have imaging. And microbleeds, and that's an instance where we're not the best, and I'll show you why. Okay, so and also for, like I said, with microinfarcts, we're looking at all the right places. I think we may not still know the answer to that question. So this was a study that we did in 2018, where we went back in the ROS-MAP cases and took sections of watershed regions of the brain. And our question was, if we look at these regions in the brain, are we going to identify more microinfarcts, and are we going to identify cases that we otherwise did not see microinfarcts in? And the answer was yes. So we went back to these regions. And we found that in this anterior and posterior watershed regions, we identified both cases that we otherwise would not have seen microinfarcts, as well as increased number of microinfarcts in this region. So clearly a susceptible regions to microinfarcts. We also found that if you looked at these regions, it was important in cognitive decline in our cohort. And so, it wasn't just that we're missing them, but we're missing components of decline if we don't take that. Okay, arteriolar sclerosis. So when I started, we did basal ganglia. A lot of people do general arteriolar sclerosis. What's the worst? We were interested in that question, and so we went back and in our same areas we took white matter from for the watershed, we went back and looked at arteriolar sclerosis. So we have anterior white matter and posterior white matter, and we had basal ganglia. And we did the other two regions blinded to what we called it through the basal ganglia. We also had a separate project where we were looking at spinal cord. And there's actually arteriolar sclerosis in the spinal cord if you take spinal cord. So you can see just here, this is just a figure showing normal to very severely occluded small vessels with hyalinized thickening and near occlusion of some of those lumens. In this particular study, we looked at how does risk factors differ? So we've seen in the past, we have a study in the past showing that blood pressure, high blood pressure, actual blood pressures is related to arteriolar sclerosis in the brain, and no one's probably very surprised about that. It's also related to infarcts. But we wanted to ask was, since we're seeing something slightly different in these white matter regions than we are in the basal ganglia, are there differences in where the risk factors actually are related to the damage? And surprisingly, the answer was yes, we did see a difference. First of all, I also want to show that they're all highly related to each other. So it's not as if these are it's isolated. If you have bad arteriolar sclerosis, you often have it in these other regions too. So you can see here the correlations, they're high, but they're not the same, right? 0.28 for basal ganglia and frontal white matter, 0.27 with parietal, 0.49 for parietal and frontal white matter. And you can see with spinal cord, it's even less, just with the frontal white matter. So what we found in this preliminary, I think of it as preliminary because I think we still have work to do, is that there are some differences in what's related to blood pressure. So DBP is diastolic blood pressure. And if you go on the right, one down, you can see that white matter in the frontal white matter was related to diastolic blood pressure. I would have guessed it would have been the posterior white matter. Oh, it is posterior. Wait a second. I take that back. I did guess that. Okay, never mind. Anyway, so blood pressure was related to posterior white matter. I apologize. And diabetes was related to frontal. So quite interesting that that these diseases that we talk about during life are actually impacting vessels differentially in the brain. And yeah, so I think that's really quite interesting. We actually, the list goes on. If you guys, I forgot to put the reference here, so I really apologize. I can share it with you if you want the reference. Or was it on the previous slide? Might have been on the previous slide. Okay, so why do we care? We care because there's risk factors, but we also care because it might tell us something about relationships in the brain. So it might tell us different things. So when we look at our basal ganglia arteriolar sclerosis, it's very related to blood pressure. It's related to cognitive decline. But when we started really looking at the white matter arteriolar sclerosis, what we found was that it was related more to tau in the brain than our basal ganglia measure. So previously, when we looked at arteriolar sclerosis in the basal ganglia with our outcome of how much tau you have in your brain, we saw nothing, which was really surprising because lots of people have. There's reports, right, of these relationships or not having these relationships. Or, is atherosclerosis, arteriolar sclerosis related to AD pathology? And that was the first time we saw a direct relationship between small vessel disease and degeneration, which I think is quite interesting because we weren't looking in the right place. Okay, atherosclerosis. We all look at the circle of Willis. Some people take sections. I'm not sure what they do with the sections because we're just asked for a mild, moderate, severe. designation in NAC. How good of a job are we doing with that? With atherosclerosis, again, if you look at the ROS-MAP data set, atherosclerosis is related to cognitive decline. It's actually related to a smaller hippocampus. We've shown that in some imaging studies. And it's related to white matter hyperintensities. If you look at white matter hyperintensities, though, and I'll show you that first, maybe I'll show it here first. If you look at white matter hyperintensities, what you see is that it is related to small vessel disease, just like everybody thinks it is. So you can see arteriolar sclerosis there. That's, gross infarct, arteriolar sclerosis, very highly related to white matter hyperintensities. So we're capturing some of what the radiologist is seeing during life. But are we capturing everything that the radiologist is seeing during life? And the answer is no. And we did a study where we put all of these pathologies in a model and said, if we look at the brains, or can we explain more cognitive decline? And the answer was yes. So the radiologists are seeing more than what we're able to see in the white matter. So going back here, back to the atherosclerosis, which also is related to white matter hyperintensities. What we did in this very small pilot study was look at cases with severe atherosclerosis and said, if you have severe atherosclerosis at the circle of Willis, what do your small vessels look like? So this is an example of some of the small vessels in a person with circle of Willis severe atherosclerosis. You can see on the top left an atherosclerotic smaller vessel intraparenchymally. On the right, occlusion again, mostly intimal hyperplasia. On the lower side, the lower panel, you can see there was actually a bleed around a blood vessel that had atherosclerosis in it. And then you can see meningeal vessels on the bottom right. So really interesting when we think about atherosclerosis as this large vessel disease and you look at these pictures. Not sure why it's not going. There we go. Okay, so we're not capturing all the pathology. White matter, I think, is more of an issue, and I think it's something we all as neuropathologists need to think about. We've done studies looking at white matter with just using staining and semi-quantitative. It's not very good. The imaging is much better at picking up white matter changes. I think there's probably more that we can do using special stains, but that's probably more of a research area rather than something all the centers would do. Microbleeds is also, and I'll show you pictures, also something that radiologists can do better than the neuropathologists. I think enlarged perivascular spaces and perivascular tissue changes, however, are another area for us to really think about. So just pointing out that if you look at ex vivo MRI and you look at for microbleeds and then you match it to the tissue, that we're missing microbleeds. So we're not seeing those. So that's one of the things that you might have. I think 2 of the cases had severe cerebral amyloid angiopathy, but these were cases, and you can see here for the neuropathologist the imaging and then the brain and how hard it was for us to find these things, because these things have the blossoming effect on imaging. So they look big on imaging, but we really had to look for a lot of this pathology. The problem with ex vivo imaging is it picks up acute hemorrhage too, which is often just perimortem hemorrhage. But we're missing microbleeds in people in aging. Enlarged perivascular spaces, again, that's something that can be seen on imaging. We see it more probably than the imagers do. Maybe not, I don't know the exact prevalence. But you can see here what we did is we had ex vivo images of enlarged perivascular spaces and said, my question to the radiologist, how do you know that's an enlarged perivascular space? Is it possible this is something else? Let's take a look and see what we find. And you can see here that we did find the enlarged perivascular spaces. And these are really curious because I don't think most of us capture this somewhere. And you can have cases, as you know, as the neuropathologists know, which have very severe enlarged perivascular spaces. And they kind of all look different, and they never look like they'd be healthy for your brain to have them. In addition to that, surrounding these enlarged perivascular spaces, as most of you know, there's often tissue rarefaction that we're not capturing. So, I mean, in the old days, in old pathology, they used to have a name for it, a tat crible. I don't know if anybody remembers that. But I mean, it starts looking cribiform in the basal ganglia. We're not capturing any of that right now. And we're certainly not capturing the more subtle changes that we see around these blood vessels with tissue rarefaction, with hemosiderin, and the other changes that are happening there. So that's just a snapshot of things I could think of off the top of my head, of things that we're missing. I think it's something we all need to think about more, is when it comes to vascular pathology. The answer is yes. I think we can already do a better job if we at least take the watershed regions to look for the microinfarcts, and maybe just think about those people who are investigating vascular disease, what we should really be doing when we look at the perivascular spaces also. Thank you.
So we're running a little bit late, so there's no time for questions, so we'll move on to the next speaker, Dr. Suzanne Van Vello, who is an associate professor in neurology at Harvard Medical School, and she is the director of the Translational Cerebral Amyloid Angiopathy Research Lab at Mass General. And the title of her talk is Neuropathological Correlates of MRI Visible Small Vessel Disease Lesions. Thank you.
Thank you so much for this kind introduction and for the invitation to present here today. And I apologize I couldn't be there in person. And thanks for Dr. Schneider for really setting the stage. And I will hope in the next few minutes or so to continue the story and share with you some examples of how we can use ex vivo MRI to study the neuropathological correlates of MRI visible lesions that we often encounter in the context of cerebral small vessel disease. And these are my disclosures. So here you can see some of the key manifestations of cerebral small vessel disease that we encounter on brain imaging. So these white matter hyperintensities, lacunes, microbleeds, microinfarcts, these perivascular spaces, and cortical superficial siderosis. And as you'll appreciate, these are really not the small vessels themselves, but rather the consequences of small vessel disease pathology that we can capture and we sort of really use to identify and define small vessel disease on brain imaging. But as Dr. Schneider already beautifully showed just now, is that this is how we define small vessel disease from a pathological standpoint. So these are some examples of arteriolar sclerosis and cerebral amyloid angiopathy, two of the most sort of commonly observed small vessel diseases in the aging human brain. And it becomes clear there's a bit of a discrepancy between how we define small vessel disease on imaging during life versus how we define it on neuropathology. And we and others have used ex vivo MRI in formalin-fixed postmortem human brain tissue to really try to bridge this gap. And doing studies like this, we can really make these nice comparisons between what we see on imaging on the one hand versus what we see on neuropathology on the other hand. So just to start us off with a couple of examples, here is an example of an ex vivo T2-weighted brain scan with an area in the white matter of white matter hyperintensity. And we can match up these areas with histopathology, in this case, a Luxel fast blue staining, and really try to zoom in regionally on what this might look like under the microscope. So here we just see some examples of what the white matter looks like in an area of WMH and the small vessel disease pathology associated with it. And here's just another example of a lacune in the white matter identified here, again, on this ex vivo T2-weighted scan. And here we've been able to find it in that same area under the microscope and confirmed this rim of astrogliosis and small vessel pathology in the same area. So this allows us to do these regional sort of associations between imaging and pathology in the same brain. And a nice sort of example of how ex vivo MRI has taught us about what we can and cannot see with imaging, and it was already nicely introduced by Dr. Schneider in the previous talk, are these cortical cerebral microinfarcts. And as we know from neuropathological studies, these are really numerous in the brain, and we can encounter them in neuropathological examination, but we're not so good at imaging them during life with MRI. Here's just an example of one of those cortical microinfarcts. Don't get distracted, this is just a tear in the tissue, but this is the actual cortical microinfarct and identified on H&E. When we zoom in, we see this rim of astrogliosis and this cavitated area and this sort of indent in the cortex, and associated with this cerebral amyloid angiopathy on this section. And this is a rather big microinfarct, if you like. It's spanning almost the entire width of the cortex. And this is really on the far end of the spectrum in terms of size. And indeed, lesions like this, we are able to capture with imaging. Here's again an ex vivo T2-weighted scan at the same area where we see that microinfarct. But then on the same section, we also observed another microinfarct here on the top left. And this particular lesion was actually not able, we were not able to visualize this on the ex vivo scan. So there's limits to what we can detect in terms of these microscopic ischemic lesions with brain imaging. And so we and others have been also interested in these hemorrhagic manifestations of small vessel disease, and particularly in the context of cerebral amyloid angiopathy, and how we've been using ex vivo MRI to first try to understand the pathological correlates of these lesions, and also the small vessel pathology associated with these. And specifically, as already mentioned in the previous talk, like we need ex vivo MRI to find these lesions post-mortem and try to study them microscopically. So in a nutshell, so when we see microbleeds in a cortical or lobar distribution, this is indicative of cerebral amyloid angiopathy, whereas microbleeds in deep areas of the brain are more strongly associated with arteriolar sclerosis. And so this is an older study that we did a while ago now, also using ex vivo 7 Tesla MRI in brain slabs of patients with small vessel disease. And this is just to showcase what this comparison might look like. So there are 3 cortical microbleeds here on the ex vivo scan that we were able to capture on the H&E stain section labeled 1, 2, and 3. And just walking through these lesions, here's an example of one of those acute microhemorrhages that could be related to the perimortem events of how the patient passed away. But this is characterized by these still intact red blood cells that have extravasated from the blood vessel wall. But in these are here's an example of an older or a subacute to chronic microhemorrhage characterized by these blood breakdown products and hemosiderin deposits that corresponds to this lesion here on the scan in number 2. And then finally is another example of a chronic or old microhemorrhage, this sort of focal cluster of these hemosiderin-laden macrophages. And you will appreciate that when you're looking at the skill bar, this is a very small lesion, about 100 microns in diameter, and we're still able to capture these with MRI. And this is due to the so-called blooming effect of the related to the iron content of these microbleeds. And so because of the blood breakdown process and the release of iron, we can see these microbleeds quite well with imaging, even though they're very hard to see on routine neuropathology. So using a little bit more targeted approach and with high resolution ex vivo MRI and targeted serial sectioning, what we've aimed to do in our lab is try to find these microbleeds and then really look at the vessels associated with these lesions and see what we can learn from the pathology that has potentially led to these vessels to rupture. So sectioning through these lesions, we're able to identify those individual culprit vessels, and then we can follow that up with histopathology to learn from what might have happened in those cases. So here's just an example again in cerebral amyloid angiopathy. So we're looking at a cortical microbleed. And the first thing we really learned from these observations is that these lesions really occur from cortical arterioles. So these are the vessels that stem from the piled surface, from the leptomeninges, and dive into the cortex. And these hemorrhages really occur around sort of where the vessels bend into the cortex, around these cortical arterioles. When we stain the adjacent sections with amyloid beta, to our surprise, we found that actually at the rupture site, there was less amyloid beta deposition in the vessel wall than we had anticipated. These vessels looked like abnormally thickened, almost like these balloon-like vessels, and a fragmentation of the vessel wall, and only a little bit of amyloid beta left here at the rupture site, as compared to neighboring vessels that still looked pretty intact. So taking these observations together, it looks like these vessels undergo additional steps after amyloid beta deposition, including some form of vascular remodeling potentially, that lead these vessels to rupture and to bleeding. And indeed, when we look in these areas at other vessels that are still intact but are associated with high microbleed numbers in these cases, we see that they are strongly associated with these types of vessels that have undergone remodeling. So here's an example of a remodeled vessel where we see this abnormal thickening both of the wall and of the vessel lumen. And we see loss of amyloid beta from the vessel wall at this particular site. And early signs of blood-brain barrier leakage in the form of fibrinogen extravasation through the vessel wall that is then taken up by perivascular inflammatory cells. And this is indicative of a von Sattel grade 4 vessel that we see in CAA. And so we're following up these studies and also see how this might relate and be implicated in understanding sequence of events leading to hemorrhage, for instance, in the context of anti-amyloid immunotherapy, where we see these types of hemorrhages quite often, and how these remodeling steps might be implicated in the pathology of these lesions. And then another hemorrhagic manifestation that we're quite interested in the context of CAA is cortical superficial siderosis. So this is the chronic manifestation of acute convexity subarachnoid hemorrhage, and it can manifest either in focal siderosis or in disseminated siderosis. And again, insights from ex vivo MRI, where we're able to pinpoint those areas and then follow up with histopathology, we found that we could actually confirm that this is indeed bleeding from the leptomeninges. So we see the piled surface here of an area with siderosis and these iron-positive cells here surrounding the leptomeningeal vessels and really lining the cortex here, underlying these vessels. When we zoom in, we see these hemosiderin deposits, really indicative of bleeding from those types of vessels into the cortex. And in a similar fashion as what we observed with microbleeds, we found that siderosis is associated locally with a type of vascular remodeling, in this case in the form of von Sattel grade 3 vessels. So this characteristic sort of splitting of the vessel wall in these areas of siderosis. So again, suggesting that these vessels undergo some sort of extra step after amyloid deposition, including splitting, fragmentation, and vascular remodeling with these lesions. And then finally, I just wanted to briefly highlight studies that are ongoing and looking at the pathological correlates of perivascular spaces. So we see this quite often in patients with CAA and specifically in this white matter centrum semiovale. And it's quite unknown how these relate to cortical pathology. As we know, amyloid builds up in cortical vessels in this disease, but we see in the white matter these enlarged perivascular spaces that are presumably become more visible during aging and in the context of severe CAA. In this fashion. And this is work from Valentina Perosa in the lab, who took samples with these enlarged perivascular spaces and scanned them at 7 Tesla MRI at quite high resolution. And I think what you can appreciate is that these vessels indeed seem to be connected to the cortical portions of these vessels. So these seem to be vessels that run from the piled surface, go into the cortex, and then continue into the white matter. And it's really the white matter portion of those vessels where these perivascular spaces seem to become dilated and enlarged. And so Valentina was able to follow up these samples with serial sectioning in the lab and then look at where the amyloid beta builds up. And what she found that indeed it is along the white matter portions of vessels that have quite severe amyloid beta deposition in the cortex that we see these perivascular spaces enlarged. So presumably this could indicate some sort of fluid imbalance or buildup or stagnation of fluid in vessels that are presumably not capable of clearing the amyloid anymore to the surface of the brain. So there's this blockage of clearance failure potentially that results in the widening of those spaces. And it's something that we are actively looking into in the lab at the moment. And with that, I just want to thank all the people involved in all of this work, our collaborators, our funding sources, and most importantly, the families of our patients who generously donated their brains for our research. And thank you so much again for the invitation. And happy to take any questions.
So time for a couple of questions. And maybe one question for both of our speakers to address is you're routinely doing postmortem MRI and guiding your sampling of the neuropathological sections based on the postmortem MRI. And we've just heard that only about 1/3 of ADRCs are doing postmortem MRIs. So would you perhaps want to comment that it might be a more optimal to try to do postmortem MRIs that will allow us to more fully sample the full extent of the vascular pathology and allow us to do better correlates with the clinical phenotype.
It's on. Oh, thank you. So we actually don't use the ex vivo to inform our autopsy report. So we've done separate studies where we look at the ex vivo and then look back at the case. So currently, we're blinded to whatever was seen in vivo or ex vivo scans. So we don't even know if they're calling an infarct during life. So we do that purposely so we can look at that relationship between what's seen on imaging and what's seen on pathology. But I think you can make arguments either way, and that's one of the things I thought about when you were presenting the data, was people talking about, oh, we use imaging, and what does that exactly mean? You know, so are they looking at in vivo imaging and then doing looking for the infarcts that were seen? Right. You know, that piece I think is important because then things become a little bit circular. You know, there's some different research questions that can be answered, but I think both are valuable.
Yeah. Excuse me. Just to comment on the vertebral band spaces, because it's apparent that those are associated with infarcts and white matter hyperintensities. And there are very few studies, but the ones that look say that the perivascular widening might not be an independent factor, and that it's really the white matter intensities and the infarcts that are driving phenotype. So that's an opportunity for us to actually quantify this, because there are cases, for example, with giant and large vertebral band spaces that are completely incidental in young people. So there are probably multiple etiologies there, and it's just complicated.
Okay.
Yeah, I'd love to comment on that if I may. I don't know if there's time or if you can hear me.
Go ahead.
Yeah, thank you. So thanks for that comment. I think so the work from Valentina Perosa I just mentioned, she looked quite systematically it was in a cohort of CAA patients, and she found that the degree of perivascular space enlargement was indeed associated with CAA severity. But not only that, she also found that white matter rarefaction, which is one of the, I think, pathological correlates of white matter hyperintensities, also contributed to the effect, and as well as arteriolosclerosis severity. So as you said, and I completely agree, it's a very complex pathology, and multiple etiologies can contribute, I think, to this observation. So definitely something to keep in mind.
Right. Thank you very much. So our third speaker is Dr. Shino Magaki. She's a neuropathologist at UCLA and co-director of the Eastern Center Brain Bank. She will be talking about the neuropathology of cerebrovascular disease at UCLA.
Good morning, and thank you very much for the kind introduction and for the opportunity to present some of our experience with examining cerebrovascular disease on autopsies at UCLA. I'd like to highlight on cerebral amyloid angiopathy, as that has been a long-standing interest in our lab. Multiple pathologies are known to underlie cognitive impairment, and has been beautifully shown by Dr. Schneider and Dr. Mambalou that vascular disease is especially important in the elderly. This is a figure from one of Dr. Nelson's review papers that show that in the past, in the clinical cohorts, it was assumed that Alzheimer's disease explained the majority of dementia, but actually in neuropathologic cohorts, it shows that the vascular multiple pathologies, especially vascular disease, is important, especially in the older population. Important study, community-based autopsy study by Dr. Schneider showed that more than 50% of patients with dementia showed multiple pathologies, and that the presence of multiple pathologic diagnoses increased the risk of dementia threefold. So the incidence of pure vascular dementia, although is relatively uncommon, after a certain age, the majority of patients show some degree of vascular pathology, and the lesions that we all look at have been presented include CAA, infarcts, and arteriolosclerosis. And despite the agreement on what to look at, there hadn't been a consensus guideline on assessing this in relation to cognitive impairment until recently. And I'm sure many people are very familiar with this study by Dr. Love and colleagues, in which they looked at the contribution of these vascular lesions to cognitive impairment. Looking at many of the lesions, also reviewed in the Neuropathology NAC form, and they compiled UK neuropathologists to assess which of these are likely to contribute to cognitive impairment. And these were assessed mostly semi-quantitatively based on prior published reports, including one by Dr. Claria's group, that this shows the examples of each of the grades for some of the lesions. And although there was good agreement, excellent agreement for most of the lesions, there was some variability in the assessment of arteriolosclerosis as well as microinfarcts. Just the arteriolosclerosis, the fibrinoid necrosis, and microaneurysms, which were necessarily not seen in any of the patients in this cohort, were subcategorized as complications of arteriolosclerosis, but they can be seen as part of secondary changes for CAA, and it's incorporated into the CAA grading scheme. So they found that 7 pathologies were predicted cognitive impairment, included arteriolosclerosis, perivascular space dilation, each type of infarct, leptomeningeal CAA, and myelin loss, and came up with a model using 3 of these. So moderate to severe arteriolosclerosis and moderate to severe leptomeningeal CAA, as well as a large infarct, to come up with a low, moderate to high likelihood that the vascular pathology contributed to cognitive impairment, with a greater weight given to the infarct. And we found this for us as non-routine autopsy examination quite helpful in attributing cognitive impairment to the vascular pathology that we see. One limitation, though, that's mentioned is that the cohort was composed of 100% of Caucasians. So they mentioned that there definitely needs to be independent validation in a more diverse cohort. So focusing on one of the important lesions, CAA, that's seen in the majority of individuals with Alzheimer's disease, although it can be seen in individuals without. It's independently associated with cognitive impairment and increases the risk for hemorrhage. It's the second most common cause of hemorrhage, and causes large superficial lobar hemorrhages. But it also increases the risk for ischemic infarcts. This is a study by Dr. Huckel, and showing the increase in ischemic infarcts in patients with CAA. In our cohort, we found that there's a greater burden of microinfarcts in patients with severe CAA in this group compared to those with mild CAA. And also in Dr. Ihara's study, the density of microinfarcts were correlated with the severity of CAA in adults and whether or not the patient had Alzheimer's disease changes or not. So there's been various grading schemes for CAA over the years. The first one was by Von Sattel, in which he graded CAA as mild, moderate, and severe, including secondary changes due to destruction of the vessel wall in severe. Dr. Alikny and colleagues developed a 0 to 4 grading scheme based on the distribution of amyloid affected vessels throughout 3 lobes and the hippocampus, with 4 including changes that they term dysphoric changes or A-beta immunoreactivity adjacent to into the neuropil. Subsequent schemes have ranged from 0 to 3 or 0 to 4, depending on whether the vasospastic changes were included in a higher grade or assessed separately. But Dr. Love's group was the first to separately categorize capillary CAA. And a combination of Dr. Nesri's and Dr. Love's grading schemes were incorporated into the VSIM criteria. A little bit about capillary CAA. It's they have different characteristics compared to CA affecting larger vessels. The larger vessels have predominant A beta 40 deposition, whereas the capillary CAs have predominant A beta 42 deposition, such that the ratio of A beta 40 to 42 is similar to that of plaques. And Dr. Adams described the surrounding neuropil, the A beta reactivity in the surrounding neuropil as pericapillary A beta, and reserved the term dysphoric changes that we saw in the larger vessels to plaque-like deposits of A beta extending out into the neuropil, but continuous with the basement membrane of a CA-affected capillary. So much of the work on capillary CA has been done by Drs. Dahl and Adams, and they subcategorize CA into two types, whether or not there was capillary involvement. So they called capillary CA type 1 and CA that didn't involve capillaries type 2. And they found that capillary CA was more strongly associated with Alzheimer's disease and a greater A beta plaque load. They also showed that the capillary CA was strongly associated with the EPOE epsilon 4 allele, whereas non-capillary CA was associated with epsilon 2 allele. And although CA is overall associated with increased microinfarcts, that in this hippocampus specifically, they only found that the capillary CA or CA type 1 was associated with the microinfarcts. And finally, in our cohort, we found that evidence of blood-brain barrier breakdown, fibrinogen leakage, it was only seen in capillary CAA and the occipital lobe. So CAA predominantly often affects the posterior parts of the brain. So the occipital lobe is the most severely affected usually. So it's not surprising that the cerebellum is also commonly involved with CAA, although it's not included in any of the grading schemes. And it's relatively rare to have CA-associated hemorrhage in the cerebellum. This is some small studies that looked at CA in the cerebellum. One by Dr. Okamoto and colleagues who looked at 60 cases that showed CA in the occipital lobe. And of those, almost half showed CA in the cerebellum. Only 10% showed capillary CAA, but only 27% showed A beta plaques in the cerebellum. And our cohort, we had a small series of cases with a high A3 score, A score on the ABC scoring, that also had the similar percentage of cases with CAA, but we had a much higher proportion of cases with capillary CA, maybe due to the fact that we had a higher proportion with A beta plaques, because previously been shown to be strongly correlated. Interestingly, we didn't see any infarcts. So in summary, this has been beautifully shown by the prior speakers. Vascular disease is a significant contributor to cognitive impairment, and recent development of consensus guidelines on the assessment in relation to cognitive impairment, which is probably familiar to everybody. CA is seen in the majority of patients with AD and increases the risk for both hemorrhages and infarcts. Capillary CA, we think, is a distinct type of CA that's strongly associated with the EPOE epsilon 4 allele and A beta plaques. And finally, cerebellar CA, including capillary CA, is common and rarely associated with hemorrhage, but may not be associated with infarcts, as it is in cerebral hemispheres, although we need a lot larger cohort to assess this. So with that, I'd like to acknowledge the participants and their families. Without them, never be able to do any of this. And my mentor, Dr. Harry Winters, our wonderful lab manager, Kazu Williams, and the Department of Neurology for all of their support. And thank you very much for your attention.
Time for a couple of questions. Nothing? Okay, well, thank you very much. The next speaker is Dr. Dominique Leitner. So the last speaker of this session is Dr. Jerry Liu. He's a neuropathology fellow at UC Irvine, and he'll be speaking on the workflow for automated segmentation of arteriosclerotic blood vessels on digitized H&E stained brain tissues using deep learning. Thank you.
All right. Thank you very much for having me. Hello, my name is Jerry Liu, and I'm a first-year neuropathology fellow at the UCI Department of Pathology and Laboratory Medicine, Division of Neuropathology. And as you mentioned already, I'm going to be presenting on automated segmentation of blood vessels on digitized H&E stained brain tissues using deep learning. So taking a step back at the 10,000-foot view, the primary application of machine learning or deep learning for the ADRC may be to increase the granularity of neuropathological information gathered in each autopsy evaluation. The hypothesis and aspiration is that increasing granularity may potentially reveal deeper insights into the nature of Alzheimer's disease, such as the relationship between neuropathological features and clinical outcomes. For example, in this low granularity picture, we can see an object, but it is difficult to distinguish what the object is. When the same image is shown with increasing granularity, we can recognize that the object is a dog, but it's difficult to analyze detailed features of the dog. And finally, in this high granularity image, we can analyze detailed morphological features sufficiently to recognize that this is a multi-poo. And she's actually my dog, a very cute picture of her when she was 6 months old. Similarly, the idea is perhaps increasing granularity of data on neuropathological features may reveal to us a better picture of Alzheimer's disease. Zooming back in from the 10,000-foot view, our project specifically focuses on arteriolosclerosis, for which a semi-quantitative scale is the most commonly used for grading. This scale is divided into none, mild, moderate, and severe. One drawback is that this semi-quantitative scale has moderate inter-rater reliability that ranges from 0.45 to 0.91 of a Quetz AC2 coefficient. Potentially, quantitative approaches to brain arteriolosclerosis may offer a more reproducible and robust alternative. One of several quantitative metrics is the sclerotic index, shown here. However, applying a quantitative approach to all vessels on all slides of all cases in a study would provide high granularity morphometric data on vascular structure that would facilitate the study of cerebral vasculopathy. However, doing so is not feasible manually for a neuropathologist. Deep learning shows promise for automation of quantification through a method called semantic segmentation. So overall, in our pipeline, so far we input 40 whole slide images from frontal and occipital white matter of 14 participants from 3 institutions, UC Davis, UCI, and UCLA, into this deep learning pipeline, which consists of 5 steps. The first step is whole slide image tiling, followed by blood vessels classification, blood vessels centering, arteriolosclerosis classification, and finally, arteriolosclerotic vessels segmentation. So in the first step, it's a very standard practice to first tile a whole slide image. Whole slide images often come in sizes of gigapixels, and it's too large to fit into the memory of even the best computer systems. So unfortunately, we have to tile the image usually into 512 by 512 pixel patches. The pixels can vary. Then following that, we use a modified attention U-net to segment out vessels and this allows us to classify whether or not a given patch contains a vessel. So these are sort of patches that do not contain vessels, and these are patches that contain vessels. And finally, we take the patches that contain vessels and we put them through a recursive object of interest boundary detection algorithm. It uses the neural network to detect the object, and then we slowly sort of try to create a new patch with the object a little bit closer to the center. And this is repetitively done so until the object is now in the center of the patch. And the main reason we're doing this is that in some patches, we notice that the object of interest can be on the side of the patch. There can be a different angle of it. The object can be cropped as well. And this overall, we hypothesize decreases the model performance. So finally, after the patches are centered, some of the vessels are normal vessels that don't contain arteriolosclerosis. And so we do another classification step, arteriolosclerosis classification. And this is using a standard convolutional neural network with a pre-training on ImageNet backbone. And so this step, we're able to sort out patches that have vessels but don't have arteriolosclerosis, and vessels with arteriolosclerosis. And then finally, another segmentation model completes the final segmentation, where we can the algorithm is able to detect the vessel walls and the vessel lumen. So the vessel lumen is yellow and the vessel walls are green. And then along the way, we do need to we find that something that improves model performance is data augmentation, including geometric transformations and color transformations. And these are applied to all four models: blood vessels classification, arteriolosclerosis classification, and arteriolosclerotic vessels segmentation algorithms. So a key finding that we do obtain in this study is that we find that patches that have the object of interest on the side of the patch that may be cropped don't perform as well, and that the model overall performs better when the object of interest is sort of centered in the patch. And this sort of makes sense, I think, even for a human being. It would be more difficult to outline the blood vessel or recognize whether or not this has arteriolosclerosis if it's sort of cut off, and it's much easier if it's on the center. So preliminarily, some of the results that we have is that so this is the method without blood vessel centering. The Pearson correlation coefficient is 0.55 with the p-score less than 0.001. And then finally, after centering, so this is after the vessels are centered into the middle of the patch, the Pearson correlation coefficient is now improved to 0.81 with a p-score of also less than 0.001. And we also find that for these patches with centering, we use something called the DICE score. The DICE score is equal to is a calculation where you look at the overlap between the mask, the annotation mask, and the segmentation output that the machine has. So what you compare what the human has done and what the machine has done. So we look at, so X is sort of, you could say, the machine, and then Y is the human. So you look at the overlap between what those two masks, and you double it, and then you have the human mask plus the machine mask together as the denominator. And so theoretically, if the machine mask and the human mask completely overlap, then this would be divided by this would be sort of 1 + 1. This would be 1 × 2. So this would be that you would obtain a DICE score of 1 in total. So then in our machine, we find that we obtain a DICE score of 0.71 for the vessel walls and lumen combined. And for the vessel walls only, 0.71. And it actually does slightly worse for the lumens only, with 0.68. There's some thought for why it's doing a little bit worse for the lumens. We think one thing is the DICE score overall tends to be lower for a object that has a smaller area, and the lumen does have a small area, so that could be one explanation. Another explanation is we noticed that there's some irregularities in the vessel hyalinization in an example that I'll show a little bit later. So there's some these are our hypotheses for why the lumen doesn't perform quite as well. And then finally, another preliminary result is that for the classification of arteriosclerosis, the model does do pretty well. It's accuracy of 0.93. But we're going to continue to optimize this model, and then we're finally going to run a full evaluation and test on the whole pipeline. And we plan to compare the results with the same evaluation done by 2 neuropathologists, and to see how well the model does compared to neuropathologists. So finally, this is a sort of figure showing how the model performs. So this is the manually annotated mask that was done by myself and some other undergraduate associates. And we also have 2 neuropathologists doing these manually annotated masks. And then finally, we have the model segmentation output from the pipeline. So you can see here the model, the green is for the vessel wall, and the yellow is for the lumen within the vessel. And something we did notice that might be increasing difficulty for the lumen is if you look at here, this vessel has maybe this irregularity in the hyalinization of the vessel, and it creates what appears to be a pseudolumen. And here you can see that the model is picking up the pseudolumen, but the human annotator thinks, at least we're taught that the pseudolumen is not true lumen. So the model is perhaps struggling to understand that. So overall, we are working on finishing the models training for all the models in the pipeline, and we're going to go ahead and compare with the attending neuropathologists. So I think the takeaway messages from the preliminary results are that automated segmentation of vascular structure using machine learning is feasible, and then also that centering on the object of interest overall improves the segmentation performance. And then I think something that we need for next steps is we need more whole slide images and participants from disparate institutions, because something that can affect the model performance is slide processing. There's different types of slide staining, different procedures for processing of the slide that can affect eventually the model performance, because the slide could appear a little bit more pink or eosinophilic, or it could look a little bit more basophilic, a little bit more purple, depending on the processing. Also, even depending on the vendor that you use to create the whole slide image, that can also create different artifacts in the way the whole slide image looks, and that affects model performance. And of course, sometimes if you have more whole slide images, you'll reveal a more greater variety of vascular structure that could challenge the model. And then also you could have a different participant population. And then also something we do find that we're learning in this study is that a detailed segmentation mask, the annotation for this is quite manually laborious, costly to obtain. So we are thinking of some ways to design an algorithm that can maybe go around the requirement for a laborious manual mask annotation. So I think, yep, these are our main 4 takeaway messages for our study currently.
Okay, we're open to some questions.
Hi, Eddie Lee from UPenn. That was great. Have you thought about segmenting the Vercal band spaces? So then you could get widening of the Vercal band spaces, but also look at tortuosity of vessels within a single Vercal band space?
Yeah, I think that would definitely be a great next step. I think the good part is that once we have this pipeline, it's sort of like a student. And so once you have the pipeline, you really just need the data in order to train a new model for the Vercal-Robinson spaces. So I think that would be a great next step.
So how amenable is the whole approach to automation? So it sounds like you have to do a lot of manual annotation on the method now, but you think down the road it will be more automated?
Yes, I think a very great question. Yeah, as you mentioned, the greatest challenge right now using our approach is the manual annotations required. So the classification step is quite easy. You can sort of sort it out, and a human being can sort out quite a number of patches in a relatively fast time. But the manual annotations, it requires you to annotate each pixel of the vessel, which is very laborious, and to ask an attending neuropathologist who's already very busy with clinical work to do that is also very difficult. So I think, of course, I think that maybe ultimately we'll still need a little bit of those manual annotations by experts, especially vascular neuropathology experts, and that would maybe be like a gold standard. So you have 5 experts, and then you average out the masks produced by those 5 experts. But there is some thought, there's new methods like, for example, multiple instance learning, where you have a whole slide image, and perhaps there's a NAC form where in the case, the neuropathologist evaluated arteriolosclerosis to be, let's say, moderate and frequent within the certain number of slides. And you could actually show the model just the slide itself, and then use multiple instance learning to teach it about arteriolosclerosis without necessarily annotating each and every single vessel. The difficulty with that approach is that it requires a larger number of whole slide images on the order of like tens of thousands for most of the studies that use multiple instance learning. So we only use 40 right now. So you would need a whole different scale in order to use weak supervision and multiple instance learning. And then a new approach that's just coming out is the visual language approach. I think this hasn't really been studied yet. This is the whole idea from contrastive language image clip, pre-training clip, which was, it's about being able to show like a figure of a arteriolosclerosis and then a figure legend. And you basically show it many different figures and many different figure legends, and the model has to match up the correct figure legend with the correct figure. And then by doing so, using contrastive learning, it sort of learns what a vessel is by sort of reading the figure, essentially. And then maybe this could be potentially a way to pre-train it, and then you go on and use weak learning to train it further, and then maybe last step, you could then do the manually annotating masks, and perhaps this would be the ideal pipeline to use like a lot of data, and then slowly get into sort of the more manually laborious masks at the end.
All right, well, thank you very much for an excellent talk, and I'm glad you and us are happy that we still will need neuropathologists. Okay.
Thank you, everyone.